All right. Good morning. Happy February 22nd on this day where George Washington was born and the first large mammal dolly was cloned. Today we're talking about first-line interventional therapies, a new term, something that was exciting to hear at this year's Society of Benign Prostatic Diseases. And it's a term which I think we just need to think about. And I think these types of discussions help us pave and evolve a better BPH, BPO care pathway for all of us. And so let's bring us on here and let's start. So let's talk a little bit about what the impact of the words first line had on medical therapy, as we used to call it. As you guys all know, with man versus prostate, medications are not therapeutic measures, but are temporizing measures that buy us time to get a bladder health baseline and to create detailed treatment plans for our patients. And we'll talk about prostate stents. Of course, starting from a place of gratitude for the urologist village, everything from nurses to MAs to administrative staff, C-suite executives, the OR staff, as well as healthcare industry reps, representatives, consultants from the biomedical device industry. And as always, in the fall equinox, we have our HERS, Healthcare Industry Rep Appreciation Day. And we thank you all for being defenders all across the globe, from the Americas to the European Brigade to the Scandinavian Brigade, Australia, Asia, Africa, and South America. I haven't had time to put in all the photos yet, but thank you guys so much for all the outreach and the words of support for a common message. And as always, we focus on celebrating the defenders of the future, residents from across the world. We've talked about folks reaching in from Senegal, from Egypt, from Greece, from Pakistan. That is the future if we are to change the BPH, BPO care pathway for the better permanently. As always, we draw inspiration from the arts, from Frida Kahlo and The Third Eye. How do we start to look at our BPH, BPO care pathway in a way that will allow us to make the changes we need to make it better? I've challenged all of us to kind of even just look at very common things like how we look at the world. And the word north means to the left when we face the sun. So, in fact, how does the world look when we rotate the map 90 degrees to the left or counterclockwise? How does it change the way we interact when we're standing side by side across the equator, challenging and solving problems? As always, we talk about the universe, and that is one song. And that's one song that we all sing, is that bladder health matters. Yes, the all-amazing, one-of-a-kind bladder that's so precious and so amazing that it's not even transplantable. And we need to respect the fact that there is a window of curability that exists that we need to work with our patients. And as a result, we need to go grab a chair and ask the bladder to pull up a seat to the table of shared decision-making. We spent a lot of time on these past live streams talking about how men, BPH, BPO patients, are unreliable witnesses to their own bladders. So here we need to ask them to engage, share their voice for surgical choice with not only the patient and the urologist and the healthcare system, but we need to let the bladder also participate. And when we start to rethink about and re-engineer the BPH, BPO care pathway, we recognize that medications are simply temporizing measures in the bottom right-hand corner. Let's think about screening asymptomatic men starting at the age of 50 to make sure that we're able to intervene within the window of curability. Let us elevate our prime directive from just simply managing symptoms to the preservation of bladder health. And let us understand that in the evaluation, we are prioritizing the bladder with proper counseling, triaging, risk stratifying with bladder health baselines so that we can engage in the shared decision-making process, arrive at a surgical choice when warranted based on prostate size, shape, but also detrusor function. And as always, our man versus prostate triple Ps, the preservation of bladder health, putting an end to the polypharmacy epidemic, and preventing late-stage BPH, BPO. We celebrate Defender Amanda Chung for reminding us of the bladder death, dysfunction, destruction that can ensue if we do not intervene at the right time. And it's important that we allow the bladder to have a voice in this conversation. Because behind the corner, if we delay care, the four horsemen are lurking in the shadows. On the far left, detrusor overactivity, urge incontinence, acute retention, and detrusor underactivity. And that's why I introduced during the pandemic the 5 stages of bladder health, to give voice and to give structure to the conversations we're having right here with each other, as well as with our patients. Understanding that beyond the first stage of benign prostatic obstruction, there is stage 2, detrusor overactivity, stage 3, urge incontinence, stage 4, acute retention, and stage 5, detrusor underactivity. These are the 4 horsemen of late-stage BPH, BPO. And you can get a copy of the ebook that launched during the pandemic to start this at manvsprostate.com. And we are grateful to Defender Luca Cindolo of the Italian Brigade for getting this into the Journal of Nature Prostate Cancer and Prostatic Diseases, and appreciate his academic perspective on this. And now we're looking at the triangle of triage from Man vs. Prostate, understanding that men who are at risk, they've had a history of urge incontinence, history of spontaneous retention, or maybe they have an IPSS over 7 plus a Qmax less than 15 and or a PVR greater than 100 on the left-hand side. They are at risk and need a bladder health baseline with cystoscopy and urodynamics, cystometrogram, pressure flow studies if available. So today we're talking about therapeutic categories, and specifically how do we fit stents in. Currently, as you all know, the surgical categories that we've outlined is based on, if you look at the top, the level of invasiveness. On the far right, we have the most invasive, so transabdominal permanent technologies done in the hospital at high risk. Then there's the category of IST, or invasive surgical therapies, once again, permanent technologies done in the hospital at medium risk, like enucleation, aquablation, green light. Then we have MIST, that we all very understand and know about, minimally invasive permanent technologies done in the office in general with low risk. And now we have Optilume, Core Therm, Echo Laser, and PAE. And then finally, how do we talk about LIST, or the least invasive surgical therapies, where there's non-permanent technologies often done in the office with minimal risk, and how do we fit stents within this whole discussion? Most importantly is to understand, though, we need to make sure that we let the bladders give voice to surgical choice. And here on this slide, we talk about, with those bladder health baselines, we can then assess to what extent is that detrusor under duress, and then cater the treatment plan based on that information, in addition to all the other factors, prostate shape, prostate size. And for example, here, for those who have high degree of obstruction or detrusor underactivity, we may have to give more weight to those categories that can more maximally deobstruct the prostate, like the categories of IST or the categories of most, recognizing that one size does not fit all. Big thanks to whoever's showing up. Feel free to let us know where you're coming in from. Appreciate you actually jumping in. Just a quick reminder, EAU is coming up. And in Paris in April 6th to 8th, thank you all for all those defenders getting in together and having a conversation. So once again, on this day of history, great day, George Washington was born. Cloning happened in 1977. And then we use this as a bridge into the next part. Quick disclosures, I'm a consultant from Olympus and Laborie, and I've been in the past on faculty and consultant for Teleflex, as well as done paid speaking for SRS Medical. So I just want people to know that as we go into this conversation. The discussion here is really, I just want to make sure Man vs. Prostate is presenting the community perspective on patient-centered medicine on the right there versus the academically inspired evidence-based medicine. And how do we find that space in between with a thumbs up and a smile? We want to thank Defender Carmen Gonzalez and Gita for reminding us that, yes, the patient experience is paramount, and how do we get there together from the community and academics? Very excited to see at the Society of Benign Prostatic Diseases the announcement of a terminology. We love alliterations, we love acronyms, and one that came out here, credit to the leadership, vision, experience, expertise, and innovation of Dr. Kaplan, first line, interventional technology, or FITS. And this is in regards to prostatic stents. And this is exciting. Please comment below if you'd like Dr. Kaplan to come on. He wasn't able to make it today. I did send him an email. He's in surgery. But I think it'd be awesome for all of us in the community to learn from his expertise. So feel free to let me know if you guys are interested in that as well. Why do I worry about the words first line is because of the power of linguistic determination, or the habitual uses of language that influence our habits of thought and action. Yes, words shape our thoughts, that shape our actions, that shape our habits, impacting patient outcomes. And we see that all through BPH care. In fact, as you've noticed, I've been starting to say BPH, BPO, taking the extra time. Whether we like it or not, BPH is in our vernacular now. It's on YouTube. It's in our insurance billing. But really, we're treating an obstruction. BPH is just a histology. It evolves into enlargement, tightening the prostatic channel, creating obstruction, which is a mechanical problem that merits a mechanical solution to be evaluated and considered. But I still keep BPH because it's important in our terminology to respect our origins, and that we prioritize BPH, bladder preservation health, as well as better preventative health care and better personalized health care. And lightheartedly, we shout out to Defender Mounty Ghriallais for saying that maybe perhaps it also is bladders pleading for help. Thank you, Mounty. It's awesome. But how do words shape our care? If we use the word guest instead of patient, does that change our interaction? If we talk to a gentleman who's 60 years old, but actually say, hey, Mr. Smith, you're 60 years young, how do things look for you in the next 20, 30 years? How does that change his perspective and our perspective in his care? What happens when we elevate our prime directive from managing symptoms up to the preservation of bladder health? How does that shape our actions? Loving our Canadian brethren with the terminology of T-mist or true mist, but how does that word true impact how we look at other surgical categories? If something is true, does that mean something else is not true? When in fact we know there are many good options out there for the right patient, for the right prostate, for the right technology in the right urologist's hands at the right time within the window of curability. How does it impact us when we talk about the International Prostate Symptom Score, when really those symptoms of urgency, frequency, getting up in the middle of the night are really about the all-amazing bladder? And how does it impact us when we talk about diagnostic studies that are invasive, striking fear into the hearts of not just our patients, our guests, but also ourselves, whether we know it or not? And now we're introducing, how do we use the word first line? And I think that's important. It is super exciting to talk about flexible prostatic stents. I am just beginning to understand that technology. I had the great privilege of working with some folks at the Society of Benign Prostatic Diseases. Truly awesome. Hats off to the biomechanical and material engineers, because we have reached the age of nitinol. Whether it's Provi, Zenflow, Rivermark, Butterfly Medical, Proteon, and so many others. Technology is amazing and just so creative. I mean, look at these designs. Thank you all for putting in all this effort, energy, late nights, and dedication to solving a huge problem across the world. So where do we put these? And now that we've introduced the term first line under the leadership of Dr. Defender Kaplan, let's just look it up. What does first line mean? Here it says of the highest quality or importance. And on the right, being the preferred, standard, or first choice. And here on this slide on the left, calling it the first choice, especially when talking about choosing a treatment for an illness, like first-line drugs for treating malaria or surgical removal of the tumors in the first-line therapy. And now we are already seeing it online being advertised, these flexible stents, as the preferred first-line device therapy for BPH. And I guess I hesitate. A word of caution. How do we find that sweet spot in between? Preferred to whom? The bladder? The patient? The provider? The healthcare system? Unclear. First line, I also think we have to be careful about that. How does that impact the shared decision-making process? Does it negate some of it? Does it put pressure on that process? Does it make assumptions? Does it create biases? I think we need to really think carefully about using that word first line, because one size does not fit all. First line for one man may not be first line for another. First line for one bladder may not be first line for another bladder in duress, under duress. And remember, it's just so much more complex. When we look at solutions for the BPH, BPO care pathway, look at the efficiency and effectiveness of it, it's in that sweet spot in between where we find good health policy and we find good solutions with good outcomes. when we balance the four elements of efficiency: treatment durability, economic sustainability, man's vitality, and the window of curability, where we optimize the preservation of bladder health. Because yes, first line for one is not first line for all. In this previous slide, we remind ourselves, one size does not fit all, and we need to factor in many things, not just the four elements of efficiency, but also prostate size, prostate shape, and as we see here on the far left, detrusor function based on a good bladder health baseline. Can we learn from the past? Of course. Where can we look to? We can look to first-line medical therapy. In the 90s, in the 2000s, we saw the emergence of a huge pharmaceutical industry for the BPH, BPO care pathway, $4 billion a year, starting off with drugs like tamsulosin, finasteride, dutasteride, originating from terazosin, doxazosin. And at those times, it played a role because the morbidity and mortality of the only other options we had back then, which were electrosurgical TURP and simple prostatectomy, yes, it had a more favorable benefit to risk profile. But it now, in the modern era for the modern man, has created cognitive dissonance. We're advertising it throughout the guidelines, NICE, EAU, AUA, that medications are first-line therapy. But yet, 2/3 of men on this slide, they're not satisfied with medications. And 2/3 are interested in something else. And I think that's where a lot of people were talking about the prostatic stents. And yes, together we need to do better. We need to be better. When 64% of men who are being seen for BPH, BPO are on medications, and we're only getting about 2-3% who are actually undergoing deobstructing procedures. And so that solution is important because the bladder is so precious. And here on this slide, we remind ourselves that when we delay care, if we kick the can down the road, like Defender Dean Elterman reminds us, we can end up intervening too late outside of the window of curability that we've been talking about now for the last 20 years. On the bottom left, we salute Defender Andrea Tubero from the Italian Brigade for highlighting this back in 2001, 2003, showing that back then, after simple prostatectomy, only 61% had complete resolution of symptoms because we had not intervened at the right time. And when we look at what happened with first-line drug therapy, when we thought of it as first-line, it was delaying deobstruction, increasing the rate of adverse outcomes. If we look at this study here, this is from 2011 from Canada, looking at cohorts of TURPs from different eras: 1988, before drugs were considered first-line medical therapy; 1998, when drugs were just coming of age; and of 2008, when drugs had been definitely first-line mainstream standard therapy. How did it impact? Well, we noticed that overall, during that 2 decades, TURP usage decreased by 60%. And the number one indication of failed drug therapy for having a TURP increased from 36% to 87%. More worrisome is that if you look at issues of stage 4 retention, you can see here that between the years 1988 to 2008, men showing up for surgery in acute retention increased from 22% up to 43%, doubling. Men showing up for their TURP in chronic retention increased from 14% up to 40%. In fact, we also saw an increase in the number of guys showing up for their TURP in renal insufficiency with hydronephrosis or backing up of the urine to their kidneys. And their postoperative outcome was also adversely impacted when originally only 3% had issues getting their catheter out at the time of discharge. By 2008, almost 30% had problems getting their catheter out at the time of discharge. And as a result, in the overall, the postoperative complication rate between 1988 and 2008 increased from about 15%, doubling up to 31%. And then more recently, out of the UK NHS, we saw in this study from Young, once again, we're seeing increased rates of acute retention. In 1990, in this study, in this cohort of 100 men undergoing TURP, 33 had acute urinary retention when they had their procedure done, versus in 2010, looking at a cohort of 113 men, 77 men presented in acute urinary retention, more than doubling. And then if we look at longer-term studies between 1990 and 2010 here, we can see that in that first cohort in 1990, only 2 men required to be on a long-term catheter despite deobstruction, versus in 2010, 13 or 11% were failing despite deobstruction because we were intervening too late, because we were believing in first-line medical therapy that was delaying deobstruction. Similarly, we saw an increase in the number of men with bladder dysfunction, shown here as storage LUTs, where the cohort in 1990, only 1 of the 100 had storage LUTs postoperatively versus 9 or 8% of them in 2010. And so when we go to systems thinking, looking at the iceberg model, how do we make an improvement? What's going on here? What happened? Well, if we take it to the next level and say, hey, what were the events that we're observing? Well, we're seeing men show up in the emergency room in retention, the 4th horseman, sorry, that's a typo there, of the 5 stages of late-stage BPH. There's a pattern going on across the globe, an increasing number of retention visits to the emergency room. The tsunami of late-stage BPH, BPO is starting to happen globally. And it's because we have a system in place, a structure in place based on our guidelines, EAU, AUA, NICE, where medications are seen as first-line therapy. Those words, first line, are shaping our actions, our habits. And it stems from a mental model where we believe that drugs are a solution, chemicals are a solution for a mechanical problem, when in truth, we need a mechanical solution for a mechanical problem. And that's why we're excited about the prostatic stents. And once again, Man vs. Prostate is just a community voice trying to focus on patient-centered medicine, trying to find that sweet spot with the academically inspired, evidence-based medicine. And we're trying to find that sweet spot together. I see someone else jumped on the live stream. Thank you so much. Feel free to shoot out a quick comment. We'd love to hear your thoughts. Just trying to... So yeah, we appreciate the leadership from Dr. Defender Kaplan on first-line interventional therapies. That's exciting to hear about. Love acronyms. Where does it fit? From our community-based perspective, it does fit in the category of LIST, or least invasive surgical therapies. Why do we think that? It's because we had to think about the definition of what does non-permanent mean. What is non-permanent technology? If you notice on those previous slides, I anticipated that this was going to be an issue, seeing the prostate stents come of age, and that's why I put permanent in quotation marks. And from my initial impression and perspective, there are 2 definitions of non-permanent technology. The first is temporarily placed or delivered technology that can then be completely removed. So like iTind, 5 to 7 days after placement. Or technology that is permanently placed or delivered but can be removed in its entirety without ill consequence at any point. And now that we're seeing with this age of nitinol, the technology that we have these prosthetic stents, and whichever definition we use, they are able to provide on the right here real, durable clinical benefits. And yes, they are less invasive than minimally invasive surgical therapy category. This is still in progress, these thoughts. Please let me know what you think. Comment below or reach out to me directly on LinkedIn. Love to hear your thoughts as we continue to evolve, refine these surgical categories, which are patient-facing decision-making aids. And yes, so do I believe stents have a role? Absolutely. Stents are exciting. Absolutely. Stents are needed. Absolutely. Stents are here. Yes. Are they preferred? Are they first line? I think we need to continue this dialogue and think about it. We need to hear from Defender Kaplan and other leading experts on the academic world to share with us their thoughts. I just would ask that folks proceed with caution before putting this all out there on the internet that technologies are preferred or first line. It puts pressure on the shared decision-making process, which I think we don't need any more pressure with our burnout rate as urologists being 50% or higher. So I just ask that please just to be thoughtful of it, do what you need to do, and I can respect that and honor that, but also be thoughtful of the shared decision-making process 3.0 for the healthcare systems, the provider, the patients, as well as the bladder, as we try and find solutions in that middle ground. And we use our third eye once again to think outside of the box. In fact, let's blow up the box and just kind of rethink things. Can we find the space in between our types of thinking? But in addition to linear sequential thinking, something first, something second, something third, first line, second line, third line, can we think of things in a nonlinear, holistic thinking approach? So, for example, the 4 elements of efficiency. Where's the sweet spot with treatment durability, economic sustainability, man's vitality, and the window of curability? Can we start to personalize the care, understanding different technologies have different capabilities? Here on the left, we talk about TWIP from the Randy paper in 1973, or the Castaneda study in 1989, understanding the benefit of commissurotomy, which is exciting. And now, can we now look at a prostate size and shape and be able to identify where are the elements of the greatest obstruction that need to be addressed and begin to personalize the treatment approach based on where are the areas of obstructive tissue. So here, for example, we have Optilume on the far right, where it does a great job on the anterior roof, right, with their anterior commissurotomy. UroLift does a great job on the lateral walls. Rezum does as well. Rezum and UroLift can treat all sizes, apparently. I don't do Rezum, do UroLift. Can treat all sizes or all grades of intravesical prostatic protrusion. And then you have iTind in the category of IST, able to treat all areas there. Not able to treat grade 3 intravesical prostatic protrusion, but able to treat grades 1 and 2. So now when we look at the patient and then factor in detrusor function, can we pick the best type of surgical intervention, the best surgical category for that prostate, for that patient at the right time within the window of curability? And so then we look at the AUA guidelines. Can we then begin to think outside the box where surgical therapy is not based just on size, as we see here in the 2023 update of the AUA guidelines, but now we introduce shape, introduce detrusor function, introduce shared decision-making 3.0, and where do we factor in stents? And that's going to be exciting to see because, yes, it does play a role. And now, can we find the space in between linear and non-linear thinking, the space between sequential and holistic integrative thinking? And perhaps it'll look something like this, where overarching prime directive is the preservation of bladder health, recognizing that we get bladder health baselines, looking at cystoscopy, plus pressure flow studies and cystometrogram if available. And based on prostate size, prostate shape, detrusor function, one size does not fit all. In the stage 1.0, or however we want to phrase it, sequential linear thinking, is deobstruction. Deobstruction is potentially first-line therapy. And then we customize it based on the categories of LIST, MIST, IST, and MOST, based on those patients' anatomy and detrusor function. And then maybe stage 2 or second line or sequentially, we address the bladder dysfunction, the detrusor overactivity, the urge incontinence with like Botox or neuromodulation, etc. at the bottom. And then perhaps in between is like stage 1.5, or where at the time of deobstruction, we can also do Botox, for example, as I've seen with Defender's Austin Slade and Defender's Amy Krambeck doing with their laser enucleation. So once again, how do we find the answers in the space in between? Well, we're hoping to get the Man vs. Prostate Manifesto out, which hopefully will outline a lot of these thoughts from a community-inspired approach. We recognize that and respect and honor the guidelines and the safeguards that academics have been able to provide through the guidelines, but is there an answer for all of us in the space in between? So we end with a wellness quote: true happiness does come from within. Thank you all for being defenders of detrusor with our cystoscopic swords and our urodynamic shields. And together, yes, let's go save more bladders. So just want to thank you all for doing what you do every day for so many patients with BPH, BPO. And thank you for all the innovators for the prostatic stents. Thank you for all you do, from Riona Ni Ghriallais. So sorry I mispronounced that name. Look forward to knowing how to say that. Christian Iorio, Shreya, Mehta, Austin Bly, Erica Lindquist, Adam Kadlec, Paul Edwards, Idan Geva. Thank you all for doing your innovation and doing all that you do for BPH, BPO. All right, we'll see you guys on the next one. Be well. Take care.